Hello and welcome to today's niche webinar, Oral Health for Older Adults in Palliative Care and Long-Term Settings. I would now like to introduce our first speaker for today, Judith Haber, Associate Dean for Graduate Programs, the Ursula Springer Leadership Professor in Nursing, and the Executive Director of Oral Health Nursing Education and Practice Program. Judy, it's all yours.
Thank you, Rachel. Hi, everybody. I'm Judy Haber. It's a pleasure to be here with you today, and I'm going to give you some background information on why oral health matters for older adults in long-term care and palliative care settings. It all began with the Surgeon General's report about 15 years ago when David Satcher, then the Surgeon General, highlighted the importance of the relationship of overall health with oral health and coined the phrase, the mouth as a window to the whole body. And so that report, while very important, didn't gain a lot of traction in terms of inspiring health professionals to include oral health in their practice or in the education of health professionals. But in 2011, between 2011 and 2013, three important IOM reports came out that talked about advancing oral health in America and building interprofessional oral health workforce capacity, and the importance of developing oral health literacy because many people, young and old, really did not know much about their oral health. And this is despite the fact that Healthy People 2020 lists oral health and identifies oral health as one of the leading health topics, population health topics. And there are a number of oral health objectives in Healthy People 2020 for older adults. And this is important because the truth is that the oral health of older adults is really in a state of decay. The Healthy People 2020 objectives really strive to improve that. And there are, as we all know, for those of us who are interested in the health care of older adults, we know that by 2030 there will be over 72 million older adults in the United States, and most will not have access to dental care, which will impact their overall health. Some of the barriers to accessing affordable dental care for older adults is that 70% of them don't have dental coverage. It is not a part of Medicare. There is also perhaps a lack of understanding about the need to continue to have routine dental care. Just because you're an older adult doesn't mean you can coast along and let the dental care that you've had all your life serve you in good stead in your older years. And then there is the limited income, the fixed income that characterizes a significant number of older adults. So when you have to pay out of pocket, you tend to pay for what hurts you, not what doesn't hurt you at the moment. So the whole notion of preventive dental care and putting good dollars towards that is often a priority choice for older adults. And finally, it is often difficult for older adults to get around, whether it's because they're no longer driving, whether they have mobility problems, have to take 4 buses to get to affordable dental care, or the like. There is a problem accessing dental services for older adults. But the poor oral health of older adults, as we'll hear about throughout this webinar, really contributes to many nutritional deficiencies, systemic diseases, pain and infection, and can actually be a significant contributor to or accelerator of death in older adults. So a new strategy was really challenged by the IOM reports that I mentioned a minute ago. because simultaneous with those reports was another very important report that brought out the importance of interprofessional competencies in promoting quality of care and patient safety. They are fondly known of as the IPEC competencies, which stress the importance of integrating team-based care and components of that, like effective team-based communication, in the education and practice of all health professionals. As a result of that interprofessional challenge, combined with the HRSA expert panel that developed interprofessional oral health competencies, as you can see on the current slide, this called for including oral health in the health history, in the physical exam, in the risk assessment, and in the action plan of health professionals other than our dental colleagues. And that means physicians, nurse practitioners, physician assistants, nurses, certified nurses, aides, community health workers, and the like, as appropriate. And of course, collaborating with and referring to our dental colleagues. At NYU in the College of Nursing, we have created an approach to accomplish the inclusion of these components in the primary care visit or in the overall care of any patient, and that is by using the he-not approach. When you transform the HEENT components of the history and physical exam to the he-not approach, you cannot forget about including oral health in the care of your patient. And there are many resources to help our colleagues accomplish that goal and to learn about oral health and how to integrate it in their practice. Smiles for Life, the web-based, free, I might add, interprofessional oral health curriculum is perfect for that. Modules 1 and 8 are probably ones you'd want to pick first, 1 on the oral systemic connection and 8 on oral health of older adults. CE credits can be earned by completing these modules. The other resource that you want to keep in mind and check out is our NYU ONEP program, Oral Health Nursing Education and Practice Initiative. Check out our ONEP website for a rich variety of resources to help you integrate oral health into your educational program or your practice setting. Included in that, on that website, is our brand new interprofessional oral health faculty toolkit that takes students or clinicians from exposure to immersion to competence in terms of picking and choosing different oral health activities and curriculum components to weave into an existing curriculum. And you will see there are links to all kinds of wonderful products there. Just as one resource to help you get started. You would probably want to check out the curriculum template for the adult gerontology nurse practitioner program, which integrates the NOMF competencies, the HRSA interprofessional oral health competencies, and the IPEC competencies in the strategies it suggests for you to use. So here are some references to help you, more additional resources. And now I'm going to turn the next component of the presentation over to my colleague, Dr. Ross Kerr from NYU College of Dentistry. Take it away, Ross.
Thank you very much, Judy, and hello to everyone. And I am the dentist on the call. I'm actually an oral medicine expert at the College of Dentistry. And first thing I want to do is I want to applaud, nursing's role to bridge the gap of unmet, oral needs of the U.S. population. It's extraordinary to watch, nursing do such an extraordinary job. And I apologize for my own profession for not being able to do as good a job in caring for patients who don't have, dental insurance. But that aside, that's another whole topic, and I'm going to get into talking a little bit more about the oral issues of the older adults in these long-term and palliative care settings. So, and also discussing your oral examination, and if the patients are, in bed, then obviously bedside diagnosis, talk a little bit about oral hygiene, and then into professional activities. I mean, there really should be a very strong relationship between medicine and dentistry. So moving on to the next slide, just a quick look at the recent literature really does, echo exactly what Judy has just discussed, and that is that there is a significant unmet oral health need of these patients, elderly patients, in long-term facilities. And just looking at this small study in the Journal of the American Academy of Geriatric Society, or the American Geriatric Society, we see that a cohort of homebound elderly were examined and surveyed, and we found that there was a great deal of disease. About 3/4 of the population had some teeth, but up to 1/4 of the population were completely edentulous. And of those, about 20% didn't even have any dentures. So they were basically just managing and functioning without any teeth at all. We had, a high prevalence of decayed teeth, patients needing restorative dentistry, people needing an extraction, either secondary to dental caries, decayed teeth, or periodontal problems. We had patients with mucosal diseases like candidiasis and other oral lesions, and we had patients who just, frankly couldn't chew. They had a very compromised occlusion, so their teeth weren't meeting and functioning properly. And then when you look at the survey, almost all of the patients had not even been visited by a dentist inside that institution. So, many of them had not seen a dentist for many years before becoming institutionalized, and the list goes on of different oral conditions, including oral pain, limitations in chewing, and halitosis, and other issues related to their dentures. Also, a major issue in the geriatric patient population, particularly in those institutionalized, is xerostomia, or the subjective complaint of a dry mouth, which usually correlates with an objective reduction in salivary output. And so the prevalence is extraordinarily high. I mean, depending on the studies that you look at, for anywhere from 20 to 70% of institutionalized patients complain of a dry mouth. And there are lots of reasons behind this. Predominantly it's a function of polypharmacy, but if you don't have the ability to chew, you don't generate, stimulation for salivary output. And there may be other, underlying comorbidities that predict a reduction in salivary flow. Well, we're in the era of the microbiome, and of course the oral microbiome is fascinating, and it's incredibly, heterogeneous, and it differs depending on where in the mouth you look. And you can see in this very busy slide that, you can actually now detect all of the different bugs in the mouth, the bacteria in the mouth, based on their phyla, based on their genera, and you can see the complexity. And what we do know is that in health, there are, the bugs are fairly well known, but as patients develop oral diseases, the flora shifts towards pathologic bacteria. And it's not just about bacteria, it's also about the fungal organisms in the mouth. So there are commensal organisms like Candida albicans that also live in the mouth, and in a disease state will become an active infection. So here is your classic patient with, plaque-induced gingivitis, and this is, of course, what we look for in our patients. We can see the plaque adhering to the teeth. We can see the erythema of the marginal gingivae, and this tells us that they have, active gingivitis. And of course, over time, when we have that oral biofilm that is not removed, it develops the inflammation, and in a cohort of individuals will progress to an increase in pathogenic bacteria that can precipitate periodontal disease, and then, of course, the reaction of the host to all of that inflammation predicts periodontal attachment loss, and we lose the supporting structures of the teeth. And we can see in this slide the moderate and severe periodontitis, and so this ultimately leads to loosening of the teeth, mobility of the teeth, and subsequent loss of teeth. And we know now that, through almost a decade of elegant research, that the relationship between this chronic inflammation secondary to, oral infection can set up the situation where systemic disease is more common, and of course these relationships, particularly the relationship between cardiovascular disease, control of diabetes, and other things like pneumonia, premature babies, and even links to possibly to Alzheimer's. More studies are needed, but there's no question that there is a relationship between, oral inflammation and systemic disease. This next slide really shows the patient with the chronic dry mouth, the xerostomia or salivary gland hypofunction, and we can see this red erythematous tongue with fissured changes. You can see the reflection. There's very little, saliva there. And they also develop fungal infections like angular cheilitis, where we have the cracking at the angles of the mouth. We have patients developing caries, dental caries, and particularly look at the cervical area, which is along the gum line. You can see some of the demineralization and sort of yellow appearing changes. This is where the decay occurs in patients who have chronic dry mouth. And here is an even more severe case where you can see the cervical decay. So that's something that you should be looking at in your patients who have been in a facility and complain of dry mouth. Of course, patients present with dentures, either partial dentures or complete dentures for those that are edentulous, and we've got to make sure that those function. We remove those and make sure that we clean those, because if we don't clean those dentures, then they can develop a denture stomatitis, and you can see the erythematous footprint on the palate of this patient from habitual wearing of the denture without taking it out at night and without disinfecting it appropriately. Patients in long-term facilities also develop pseudomembranous candidiasis, and that will be covered in a few minutes. And other oral lesions of importance are things like oral cancers and oral precancerous lesions. And these are three patients. The top, left is obviously a very advanced tongue cancer, but the cancers can be sometimes very early. And so if you see patients with an oral lesion that does not respond to conventional, just watching and waiting, you need to be considering the possibility of a malignancy, and we're delighted to take care of those patients at NYU College of Dentistry, where we have an oral cancer clinic. Judy mentioned putting the mouth back in the head and going to this he knot, which is just tremendous, and I think that is working very well in nursing education. So there are lots of different ways of assessing oral health, and I'm not going to get into which is the right and wrong way of doing this, but it's very important that you perform a visual and tactile examination of all of the oral structures, and this requires you to pull out the lip to look at every oral mucosal site using a decent light source and using your fingers to palpate, any areas of potential induration, which could be commensurate with a malignancy, and being able to look at every nook and cranny in the oral cavity. Finally, a little bit about oral hygiene. These patients, it depends on how independent they are, whether or not they can manage their own oral hygiene, or whether, the allied healthcare professionals have to get in there and help them. But either way, these patients need to have their remaining teeth brushed, a minimum of 2 minutes twice a day, using interproximal brushes in addition to get between the teeth, because flossing is sometimes difficult. I find that these interproximal aids can work very, very well. Other adjunctive things are the uses of mouth rinses, such as chlorhexidine rinses and other mouth rinses, using fluoridated toothpaste. There are prescription fluoridated toothpaste and remineralizing toothpaste in the marketplace, and there are a whole host of dry mouth products available as well in the form of gels and mouth rinses and toothpaste and lozenges and things like that. Don't forget the denture care, taking those dentures out at night, soaking them, and then brushing them with a proper denture brush, and also disinfecting them with some bleach solution, which you can just put a teaspoon of bleach in a cup of water and let them sit there. That will disinfect the dentures, and you can do that once a week. So that's a whirlwind little 10-minute presentation, and I'm now going to pass the baton on to Roseanne in Delicato, and thank you so much.
Thank you, Dr. Kerr. Welcome, everyone. It's my pleasure to speak with you today about this important care topic. For my portion of the presentation, I'd like to focus on an overview of the oral health issues for the older palliative care patient and discuss the challenges we as nurses and clinicians face in caring for these patients, especially those with dementia. We'd like to use a case-based study to talk about this afternoon, so let's begin with Mr. Hughes. He's an 82-year-old man with a history of hypertension, COPD, osteoarthritis, and Alzheimer's dementia, who lives at home with his wife. His current medications include hydrochlorothiazide, Arthrotek, Aricept, Namenda, and an albuterol inhaler. He recently suffered a left hip fracture after a fall, for which he underwent surgical repair. Postoperatively, Mr. Hughes has been admitted to a nursing home for subacute rehab. So I'd just like to reiterate some of the factors that have been identified as what puts the elderly patient at risk for oral health issues. According to the Smiles for Life website, as our population ages, patients experience multiple medical comorbidities. 80% of patients over the age of 65 have at least one medical condition, and 30% have 3 or more chronic medical diagnoses. These conditions can directly and indirectly affect the patient's oral health. Up to 14% of these patients live in poverty, with higher numbers represented by minorities. As Dr. Haber highlighted, these patients often lack insurance coverage for dental care. Many in this patient population are disabled, potentially homebound, or living in nursing facilities. Of these patients, 25% have difficulty performing at least one activity of daily living. This may negatively impact the patient's ability to perform routine oral care. And for those living in the community, there may be barriers to obtaining dental care due to geography, as Dr. Haber mentioned, and also due to the limited number of geriatric dentists. So in Mr. Hughes' case, he hasn't been to a dentist for a few years. He wears partial dentures, uses oxygen as needed, and has 4 chronic medical conditions which may complicate his oral care. So how can we begin to address the oral health care needs of Mr. Hughes? The best way is by implementing the HENOT assessment and using a standardized tool. As Dr. Kerr mentioned, there are a number of tools available which I have included in my references. In reviewing these tools, one of the easiest to use is the Mouth Care and Assessment Documentation Tool, which was created by Linda Green for the Rochester Health System. The tool includes assessment of the teeth, tongue, lips, and mucous membranes. Each element is scored between 1 and 4. A higher score is indicative of an oral health problem. If a total score equals 8 or below, then a patient would receive oral care every 4 hours. For scores of 9 or above, the patient would receive oral care every 2 hours. And here are each of the assessment areas with the related scoring parameters. So for instance, for the teeth, if they're clean, you would give a score of 1. If there is plaque in a localized area, a score of 2. For plaque or debris along the gum line, a score of 3. And for ill-fitting dentures, a score of 4. So we've used this tool and examined Mr. Yu's mouth, and this is what we find. We find that there's some localized plaque on his teeth, and although his lips are smooth and moist, both his tongue and oral mucous membranes are coated. Therefore, this would result in a score of 7, and we would plan to provide oral care to Mr. Yu's every 4 hours. So in particular for the palliative care patient, what are the oral health issues? They can include xerostomia or dry mouth, changes in taste, the presence of oral candidiasis, as Dr. Kerr mentioned, as well as the challenges that denture care can present. For the chronically ill older patients such as Mr. Yu's, his underlying medical conditions and the medication side effects place him at risk for oral health complications. When patients present with so many health problems, often clinicians and caregivers can be overwhelmed, and the dental care doesn't become the focus of care. The medical issues often becomes the focus of care. In Mr. Yu's case, someone who has COPD may have oxygen dependency, an inability to recline, and increased anxiety related to dyspnea on exertion, which may limit a patient's ability to receive dental care. Additionally, these patients are at an increased risk for respiratory infections, which can also cause complications in oral health, as this can increase dyspnea, which can limit a patient's tolerance for appropriate oral care. For osteoarthritis, patients experience self-care deficits due to joint deformity, pain, and limited hand mobility. If you can't hold your toothbrush correctly, you aren't going to be able to brush your teeth effectively. And in regards to medications such as a beta-2 agonist like albuterol and other medications, many can lead to GERD and decreased saliva production, which negatively impacts oral health by placing patients at risk for caries. Medications such as steroids can precipitate candidiasis, and other medications can alter taste perception, which can lead to xerostomia. While there are situations where a medication regimen might not be able to be changed, we need to keep the medication side effect profile in mind when we're considering its impact on a patient's oral health. For patients with dementia, they present a number of unique challenges to achieving optimal oral health. This table from the Alzheimer's Association outlines the issues in the varying stages of dementia. You can see that patients with early dementia can begin to suffer oral health complications due to memory loss and inability to perform adequate oral care. And these issues, unfortunately, get worse as the dementia gets worse. Overall, dementia leads to a patient's lack of perception and limits their ability to communicate their oral care needs. Over time, this situation can negatively affect their nutritional status, which may lead to weight loss, which then may lead to ill-fitting dentures, which can precipitate social isolation and oral pain. The cognitive changes of dementia often produce an alteration in a patient's threat perception, which further complicates our ability to provide these patients with appropriate oral care. In regards to this clinical problem, I'd like to mention work done by Dr. Rita Jablonski while she was faculty at Penn State. Her pilot study focused on identifying practices to reduce care-resistant behaviors. She found 15 threat reduction strategies which, when implemented, demonstrated improvement in the oral care of dementia patients and their oral health care scores. Since these initial findings in 2011, Dr. Jablonski has received a $1.4 million grant to evaluate the effectiveness of these strategies in the long-term care dementia patient population. I've included a link to the YouTube video for her initial work here, but if you would like additional information, you can Google her name and access her University of Alabama webpage. There you will find additional videos and articles related to her research. So just a few mentions about oral candidiasis. Since this is a frequent health complication in this patient population, clinicians must assess for its presence on a regular basis using the HENOT protocol and beginning treatment as soon as possible. In addition to appropriate treatments such as nystatin, clotrimazole, or fluconazole, interventions surrounding the use of inhalers and appropriate denture care can help reduce the occurrence of candidiasis. This can include the use of spacers, rinsing out the mouth after using a steroid inhaler, removing dentures at night, as Dr. Kerr mentioned, and cleansing the dentures per your facility's protocol. In addition to appropriate denture care, an important aspect of oral care includes denture marking. If you've ever experienced a patient leaving their dentures on the breakfast tray and having them tossed away in the trash, you know how devastating this loss can be for a patient's ability to eat and communicate, as well as how much it would impact a patient who has dementia. Indenture is a kit that can be used for denture marking, and I have that referenced on this slide. In talking about denture care, I just wanted to provide a quick review on the best techniques. Illustrated here are the results of a Cochrane review performed by D'Souza in 2009. Unfortunately, we don't have strong evidence to favor mechanical over chemical care, although Dr. Kerr supported the use of brushing to remove the biofilm that usually collects on the denture surfaces. There's a definite need here for more research in this area. So in closing, I'd like to come back to the case of Mr. Hughes. He's clearly at risk for oral health problems. This is due to his past medical history, his underlying dementia, his current medication regimen, and his nursing home admission. Unfortunately, his condition worsens and he is unable to be discharged home. He's admitted to long-term care. Since he lacks decisional capacity, his healthcare agent and family provide consent for DNR, DNI, and a do not rehospitalize order. His dementia progresses and he develops pneumonia. Subsequently, he is admitted to hospice services at the long-term care facility. And now I would like to introduce Chuck Tilley, who will talk about Mr. Hughes and will highlight his oral health issues at the end of life. Chuck?
Thank you, Roseanne. Oral health issues in the terminally ill present some unique challenges for hospice and long-term care practitioners. In the case of Mr. Hughes, and we'll continue on with this case, this gentleman, as we see multiple times, deteriorated over time. His Alzheimer's has progressed, and he's become bedbound, nonverbal, cachectic, and has developed dysphagia with a subsequent aspiration pneumonia. After a goals of care clarification with his family, they declined further antibiotics or admission to a hospital, and they entered a hospice program at the long-term care facility. We're going to follow Mr. Hughes as he transitions to active dying and look at the oral care challenges in earlier phases of terminal care and also in the last hours of life. Some of the comfort measures that Mr. Hughes was given were oxygen, morphine, albuterol nebs, and at this point his mouth care assessment score is 11. He scored a 2 under teeth for plaque and debris in localized areas. His tongue was blistered and cracked, scoring a 4. His lips were dry and cracked, scoring a 2. And his mucous membranes did show some white areas, which scored a 3. His overall score was now 11. Scoring at 11, we know now that our mouth care interventions, oral care interventions, which Roseanne touched on and Dawn, who presents after me, will actually elaborate on, now have to increase to every 2 hours. The white areas, as Roseanne was speaking about as far as dealing with oral thrush, we're obviously going to be addressing his oral thrush issues, but we're also going to be concentrating on terminal symptoms. And the objectives for this part of the presentation are really looking at the incidence and management of xerostomia, terminal secretions, and oral bleeding in the terminally ill population. One of the earlier studies done in hospice was looking at trying to quantify what were the oral issues in hospices. Now, most of these studies focused around cancer patients, and most of them focused on people who were actually receiving active treatment. So a lot of the treatment side effects were the most studied side effects, radiation or chemo. There was one study done by Alt-Epping et al. In 2010 that concentrated on cancer patients but who were no longer in treatment. So this is our terminally ill population with an N of about 101. And what they found were 5 of the most common problems in this population were xerostomia or dry mouth, dysgeusia or taste disturbance, dysphagia, halitosis, and oral pain. This speaks to very much the HRSA report and the competencies surrounding the inclusion of oral health for the palliative care and hospice nurse practitioner or physician in zooming in on oral health in the review of systems, the HPI, the physical exam, and in your assessment and plan. Another study looked at the dental needs in 12 different hospices back in 1985. And through exams, interviews, and a survey of administrators, they found that almost half of the hospices, half of the population in these hospices, accumulation of plaque and debris, as well as xerostomia, pain and general oral discomfort were issues. Acute gingivitis, mouth sores, and ulcers also issues. Other issues were halitosis, chewing, and difficulty speaking. So the first issue that we commonly come across at end of life is xerostomia. And as Dr. Kerr had talked about under the pathophysiology, you basically have a decreased saliva flow resulting in a dry mouth. Promotes caries, periodontal disease, and parotiditis. Problems at end of life, you have a lot of mouth breathing, and we use oxygen very commonly for comfort, which can be very drying to the mucous membranes, both nasal and oral. Also, a lot of the treatments that we use can cause a side effect of xerostomia. There's over 400 medications, including steroids, diuretics, antihistamines, anticholinergics, antihypertensives, opioids, and antidepressants that we commonly use at end of life that can cause xerostomia. So some of the first-line treatments, some of the non-pharmacological first-line treatments for xerostomia are going to be very non-invasive, very palliative care-friendly treatment modalities, including ice chips, flavored ices, popsicles, pineapple pieces, moistening the mouth with favorite foods. And the person at this point in time doesn't have to be able to swallow. Or if there's somebody who may have a malignant bowel obstruction and a drainage peg, you can actually place those fluids in the mouth. They can swallow, and the fluids and stuff will actually kind of drain through the drainage peg. So in those particular patients, using favorite foods or fluids to moisten the mouth is a wonderful intervention. You want to avoid caffeine, frequent sips of water, water sprays, and moistening a sponge stick, which Dr. Kerr alluded to, is not going to provide the most optimal palliative oral care, but it will palliate xerostomia. So we wouldn't routinely use moistened sponge sticks to provide oral hygiene, but we will use them to provide comfort at end of life. Sugarless gum or candy, depending on their level of consciousness, peroxide rinses. A room humidifier, a very simple room humidifier, could actually provide humidity in the air and help decrease dry mouth, dry mucous membranes. Humidified oxygen. So remembering, even with nasal cannula, to humidify your oxygen, very important. We'll talk a little bit about the oral hygiene products in a little bit, and avoidance of tobacco and alcohol, as well as simple lip balm or vitamin E for people's lips. One of the things we really want to stress in a lot of these non-pharmacologic or even some of the pharmacological treatment modalities is the inclusion of the family or other primary caregivers. At end of life, families or primary caregivers who've been involved in these patients' care for many, many, many years want to still be involved. This is a very simple way to allow them to continue that nurturing relationship and actively participate in their loved one's care up to the last hours of life. So some of the pharmacologic treatments, oral moisturizers, and Dr. Kerr alluded to these. So we commonly will use some of the commercial products, Mouth Coat, Biotine, Salivart, 3 to 5 sprays to the oral cavity, swirl for 8 to 10 seconds, swallow or spit, and repeat as needed. With these interventions, what I strongly encourage, and I encourage my nurse practitioner students and other practitioners, is to regularly schedule the mouth care. So in this gentleman who has a score of 11 on his mouth care needs are every 2 hours, I would actually, on this patient, order the mouth moisturizer with oral care every 2 hours, and then I could even include a Q1 hour PRN. The ability to keep these products at the bedside so they're accessible to both nurses' aides, family, or other primary caregivers is essential. A unique challenge that we see in the last hours of life is a palliative care phenomenon called terminal secretions. Because of the decreased level of consciousness causes this reduced ability to swallow in the actively dying patient, you have this pooling of secretions in the back of their throat, in the oropharynx, and also in the bronchi. The air moving over these secretions produces a gurgling or rattling that sometimes practitioners have called the death rattle. It is a predictor of near death and can be both distressing to caregivers and also to families. Now, a recent study did show that some families were actually not distressed by terminal secretions, but they were actually glad to see this sign that signaled pending death in patients who had suffered for long periods of time. And that was done in a JHPN article within the last year. So being very sensitive to this death rattle, to this gurgling, very important for people who are in their last hours of life. Priority nursing interventions are going to be repositioning the patient. Many times with these patients, if you just reposition them on their side to facilitate drainage or reposition them with their heads up, you can actually stop or decrease the audible secretions. Chest physiotherapy can have its usage, but remember, you've got to be very careful. It's not going to help upper airway secretions. It's not really going to help the patient cough at this point because they've lost the ability. They may be too weak, and also the potential to cause pain. Nebulized hydration with saline nebs and are very helpful at times, and oropharyngeal suctioning has very limited efficacy. It is a last-ditch effort, and suctioning is not normally recommended because it can actually stimulate more problems. We will use anticholinergics as first-line pharmacologic treatments. Atropine drops, Robenol, and scopolamine patches are very commonly used. Remember, with scopolamine patches, they readily cross the brain-blood barrier and can cause a delirium, so you have to be careful in their use. And one of the last phenomena that we see in palliative care and hospice at end of life are oral bleeding. The picture of the gentleman that I have on this slide is someone who had an oral buccal melanoma. The tumor actually invaded both his hard palate and his soft palate, and he was transferred to us from long-term care to an acute inpatient because of bleeding. He did not want to go to the hospital, didn't want aggressive care, and wanted to return home to long-term care. So some of the things that we actually did for him were positioning him, teaching him how to actually press against the lesion because he still could, limiting activity and exercises that prevent recurrence, and we actually started him on Afrin nasal spray, 3 to 4 sprays, because Afrin nasal spray, remember, will be a superficial vasoconstrictor, and with this routine of this vasoconstriction and also with pressure that was actually provided by the patient right up until his last hours of life, and then could be actually supplemented by caregivers, we were able to return him to the nursing home and his home for his last hours of life. Now I would like to present Dawn Pavlu. She's a nurse practitioner at the VA to present her section.
Thank you, Chuck. Hi, everyone. So in my section here, I'll be doing empowering the direct care worker in long-term care to improve the oral care of the elderly. I just have a disclaimer. While I work for the VA, I don't speak for the government. And for our objectives for this part of the talk, we're going to explore how the concepts of motivation and empowerment apply to providing quality care. We're going to discuss how healthcare providers' attitudes, cultural and social considerations influence oral care in long-term care, examine the quality of life in relationship to oral care, and in the end, I'll list some resources so that you can improve your oral care. So to begin with, we'll talk a little bit about motivation and empowerment. So motivation is really a force or an influence that causes someone to do something. And motivation can come from outside forces or internal forces. But generally, we motivate ourselves to do something by considering both advantages and disadvantages. So the advantage of doing something versus the disadvantages of not doing it. And we've had plenty of examples now. We've had plenty of examples now where we've seen that there are lots and lots of untoward effects of improper oral care. So that can help to get a vested interest or pride in our own work in trying to keep those untoward effects from happening or to mitigate those unwanted side effects from either medications or from as we go into the dying process. And then to empower is to give someone the power to do something. And really, to be empowered, you need the tools to do something, you need your resources, and then you really need appropriate feedback so that then you can kind of tailor your practice. So as was alluded in the beginning, the Surgeon General's report, you're not healthy without good oral health. And so when direct care staff reinforce daily mouth care, it can make a very big difference in reducing that person's risk for developing dental disease and oral pain. And dental disease is preventable with proper oral hygiene and care. So, but the Surgeon General found that, dental care is one of the most common unmet needs. Oral disease can severely affect systemic health, and much of oral disease is preventable, or at least controllable. And we talked in the beginning as well as how there are disparities in oral health and access to care. One of the biggest kind of factors in providing quality oral care comes from organizational culture. So we've learned about assessment and intervention tools such as the Rochester tool and the SCORE and using the mouth criteria for the dementia patients. And while documentation of the oral assessment is important, the point of assessment is to be alert for problems and changes in the mouth. Loose or broken teeth, lesions or sores, bleeding gums, and ill-fitting dentures need to be reported. So in this study of 12 long-term care facilities, they actually found that there was no association between what structural model you used and the oral outcome. However, what they did find was what was the most, had the most impact on quality was administrative capacity to control the caring environment, the presence of a champion, and an organizational value committed to oral health. So that really goes back to the original motivation and empowerment. And you can see how both motivation and empowerment are present in those three factors. Other reasons, of the reasons included for perceived unpleasantness towards oral care tasks was also studied. This is a Swedish study that I found, and it found that 87% of nurses and nurse assistants considered oral hygiene practices as unpleasant. And their reasons included either the patient's unwillingness, but then their own fear of causing damage, not wanting to be exposed to bad breath or bacteria, and some discomfort with either mounting or dismounting dentures or prosthetics. So of the reasons that were included in this perceived unpleasantness, only the patient's unwillingness was reduced after the staff received dental hygiene education, which means that there's a lot more that has to do with our own internal attitudes. So when we find ourselves in an unpleasant situation, what we tend to do is to develop aversion. So once we label it as unpleasant, we develop aversion and we start saying to ourselves, I don't want to do it. And then really from that aversion, we develop more of a resistance. And then we start saying to ourselves, well, I won't do it. And once we actually get through those two steps, then we actually start to have a loss in the priority of that task. And we start saying to ourselves, well, who cares if I do it anyway? And so those attitudes, as you can see, kind of spiral down and once again then contribute to not doing that task, which for us might seem menial, but as we'll see throughout my presentation now, has a large impact on the quality of life. And I wasn't able to actually put a slide in this because I just heard this study that came in from, reported through NPR last week, but there was actually a study that was done on human behavior, and it found that the feeling of disgust actually increases cheating behaviors and self-promoting behaviors. So once again, when we have that feeling of unpleasantness or disgust, it really does change our attitude, which of course then changes our practice. So that's one of the things that we as individuals can focus on. There are also cultural considerations to think about. The patient's individual preferences and behavioral risk factors are intimately related to their socio-demographic and cultural backgrounds. So contributions to cultural dissidence between the providers and the patients include a clinical experience interacting with either minority patients or patients who are other ethnicity than ourselves, our beliefs about behavior or the health of minority patients, and also perceived discrimination. And that discrimination goes both ways, from the provider who has some stereotypical attitudes towards other ethnicities, as well as then who is receiving, perceiving that they're being discriminated against because of their ethnicity. And we have to remember patient-centered care is defined by the IOM as providing care that's respectful and responsive to individual patient preferences, needs and values, and ensuring that patient values guide all clinical decisions. So next I just want to touch on our last topic, which is really social considerations, which folds very nicely into our quality of life. So, we got doggy breath. In social considerations, poor oral hygiene and dentition contributes to lower self-esteem, and from that you have less social interactions. From that you have depression, and as well as impaired intimacy. And older adults whose mouth is free of disease and pain, they may actually become more cooperative with care, which may help the nursing staff. So when we think about these social considerations, I mean, we can think about our own situations where we may have been around somebody who maybe had some bad breath. And it's like we keep our distance from them, right? And so that's what happens too between other members in the long-term care facility, keep their distance away from that person with the poor oral hygiene. And then as well, the person with the poor oral hygiene themselves probably has some feelings of lower self-esteem and doesn't want to interact. And so that all contributes to their social isolation, which of course is going to definitely impact their quality of life. So oral health is not only related to physical health, but related to overall well-being. And the consequences of poor oral health drastically alter the way a person acts and how a person lives. So again, we can imagine a person with ugly appearing teeth or dentures, and they may not feel good about the way they look, and people feel that they want to avoid them. We don't want to smile or interact with others and have this poor self-esteem, and that leads, of course, to our decreased social interactions. So that on a psychosocial level impacts our quality of life. But then on top of that, you have these other quality of life issues, problems with eating, problems with sleeping, problems with speech, and then just being in pain. All of these things definitely have an impact on your quality of life. And then, of course, from that leads to all other sort of physiologic problems from not eating, not sleeping, especially when you're looking at the dementia patients who, if they're in pain and they can't express that they're in pain, then their behavioral issues get more out of hand. So you can see how it's all interrelated. So I just wanted to include again, I know that Dr. Haber had included our Smiles for Life program, and we have our ONEP program for NYU, so I just put another slide up there for that. And I've got some more resources for you listed here. We have the Hartford Geriatric Institute. The Ontario Nurses Association has training videos that are good. You can get more from the University of Iowa. And there's a directory of oncology-based protocols through the ONS. And then there's also, I'd like to point you to the Geriatric Education Center of Greater Philadelphia, which is associated with UPenn. And they have as well more modules that you can kind of go through. And then there's just, some references as well that you can use to look back on. So thank you very much. And I believe we're now opening up to questions.
Excellent. As a reminder to our attendees, in order to ask a question, go ahead and click on that Q&A tab and type your question there. We've got several in the queue. We'll try to answer as many as possible. Our first, many items that are listed to provide the resident at end of life are acidic and are going to enhance the dental issues. Is it not better to provide things that will keep the pH up?
Who's answering this?
So basically at end of life, what we're doing is we're doing comfort food. So a lot of the interventions that you're going to be doing for a hospice or terminally ill population, remember you're doing it for a very limited time because their lifespan is limited. So we do emphasize favorite foods. They may be acidic. They may make things a little worse. Some of the interventions that we're doing, if we're drying up terminal secretions with anticholinergic, may make xerostomia worse. What you need to do is really balance that comfort with the interventions that you're doing. You may need to actually add moist mouth moisturizer and also more frequent oral hygiene in those cases. So we're really, really directing our interventions towards comfort and patient preferences.
Excellent. The next question in our queue here.
Can I comment just quickly on that as well? Some of the patients that have dried secretions, and they can rinse their mouth, can benefit from baking soda and water rinses. So that will increase the pH and sort of buffer the acidic environment. So in some situations, particularly with cancer patients, we'll have them rinsing with sodium bicarbonate rinses. And if you want to get more information about that, you can go onto the NIH site on care of the chemotherapy or radiotherapy patient, oral care. So, and you can get the recipe for that if you're interested.
Excellent. Our next question here, what do you all feel the role of a dental hygienist is in all of this? Dental hygienists love to provide oral care, none of those things that the care team feel are felt by an RDH.
Would you like me to take a go at that?
Sure, Ross.
I'm happy to do that. Well, I think the dental hygienist can play a very important role if in these institutions you can bring in a dental hygienist. That would be fantastic, and I'm sure that it would be great to have the presence of oral health care providers in these institutional settings.
Right.
But anyway.
Yes, and this is Judy, and I can add to that. I know of several locations, long-term care facilities, that do have dental hygienists come in on a regular basis, and they have been important in educating the nursing staff and the certified nursing assistants in developing and implementing oral hygiene programs for the long-term care facility residents, and have played an important role in doing that. And what we're suggesting now is that the nursing staff who is already in residence in these long-term care facilities can really become the leaders and implementers of and evaluators of programs like this for older adults and or patients in palliative care settings.
Excellent. And that appears to be all the time that we have for today. On behalf of NEACH, I'd like to thank you all for joining us today and for your participation. I'd also like to thank all of our presenters for their excellent presentations. When you finish viewing the webinar, be sure to complete the evaluation located within the NEACH Knowledge Center. Every user that has an account in the Knowledge Center will be able to generate their Contact Hour certificate directly from the Knowledge Center once they complete the evaluation. If you have additional users participating in the webinar who did not individually register for the webinar and need their Contact Hour certificate, please download this template located on today's webinar page within the Knowledge Center. Once the template is complete, send to support@neachprogram.org. The users will then be added to the Knowledge Center and contacted by email with login instructions. Again, thank you very much for joining us today. We hope you all have a great afternoon. You may now disconnect.